So first of all, I would like to thank the Vattikuti Foundation to invite me to this event and to let me speak and showcase my work. So my name is Jente Simoens. I'm a computer vision engineer at Orsi Inutech, which is the innovative department of Orsi Academy, a robotic training center in Melle, Belgium. Do I have like a clicker here or something? Okay. All right, so I think we can all agree that training for robotic surgery is very important and should be as well be scored in the correct way. Over the years, a lot of scoring methods have appeared, and classically this is done through manual assessment, but this is very resource intensive and can often be subjective to the person performing the assessment. This is, for example, an image at Orsi Academy where there is always a surgeon present next to the trainee providing feedback and scoring these procedures manually, which is of course not very efficient. Now in the latest years, with the coming up of AI and other automated techniques, we have developed less resource intensive methods to do scoring, but we have found that these are often based upon suboptical metrics with sometimes vague definitions. So that is why at Orsi Academy we have employed the proven optical metric called PBP, or proficiency-based progression, where we are really going to look at errors and base ourselves on these errors to estimate the proficiency level of the trainee. This is of course still manual, so still resource intensive, and it is not benchmarked to kinematic metrics, which are often used in other automated methods. Now in my work, I wanted to go for a performance assessment using AI-assisted instrument tracking, which would then of course solve the resource intensivity of the manual scoring, and then also calculate these kinematic metrics to benchmark on the original metrics that are used today. I am doing this on an avian model which is used to simulate anastomosis during prostatectomy, where the stomach of a chicken is sutured to the cloaca as a simulation at our lab at Orsi Academy. First of all, we did a data collection of 86 videos, and these 86 videos consist of 43 baseline videos of the first time the participants of this study did this procedure, and on the other hand 43 videos when these same trainees were considered proficient by the PBP metrics. We then labeled all these videos with key points. As you can see on the screen, we indicated several key points on the surgical instruments to estimate these instrument positions through time. This resulted in a dataset of 4,644 images, all labeled, which was then used through deep learning, so to training, tuning, and evaluation, to come to a predictive YOLO V8 model. So the YOLO V8 is a predictive, is an architecture, a deep learning architecture, which we then used to run inference, so run the algorithm back on these 86 videos, resulting in a collection of raw key point positions, which were then filtered, and then we come to the final key point positions, meaning we have the instrument positions through time for the full procedure. So this is a small animation of what we did. So you can see that the red dots, which are the tip of the instruments, are followed throughout the procedure, so we can estimate the movement of these instruments and how the surgeon is moving during this exercise. This is a result or a graph of how this looks through the whole exercise. So you can see that there's a lot of points, a lot of data here, and we can try to extract some metrics from these different movements in time. The metrics that we focused on were the total distance traveled, so the distance that is done by both instruments, as well as the average velocity, so the velocity that the instruments are moved at, and see if they can be an indicator for proficiency of the trainee. So first of all, focusing on total distance traveled, as you can see, we plotted here the total distance traveled of baseline on the left and proficient trainees on the right. and each colored marker is a single trainee. So every marker corresponds to a single trainee, both in the baseline and the proficiency. And we found that there was no true significant difference between the two groups, as we only reached a p-value of 0.13. The same can be said for average velocity, as there the difference is even smaller, and these metrics are almost equal. What we then did was to do a validation of 20 additional procedures. This was done quite recently, where we run the same algorithm on 20 new procedures and try to extract the same metrics. And as you can see on the far right, the green dots are the ones that are considered proficient. The red ones are considered non-proficient. So you can see that they are very intertwined. There is no real signal there. And once again, there is no significant difference to be found. And even more, one of the proficient procedures was actually a perfect one, which is the blue one on the right, where there was no error made at all. And on the other hand, we have the orange one, which is a very bad one with 30 errors. And you can see that these are actually very close together. So we can really conclude that these metrics are completely not indicative of the skill level of the trainee. On the contrary, this is often used as a metric to estimate this proficiency level, which is illustrated here that this is not always the case. So maybe to conclude, the three takeaway messages are that automated tracking of surgical instruments is possible, as we have seen and developed in our center. A trained AI-based system can be used to determine the kinematic performance metrics, but total distance and velocity cannot be used exclusively to determine the proficiency level of a trainee. And I would like to thank you all for listening, and maybe as a small plug, I would like to invite all of you to our Orsi Surgical AI and Telesurgery Days, which is very soon, so hope to see all of the faces I'm seeing here there as well. Thank you so much.
Now you have the people who are not proficient. So can you find out what kind of modification in their technique to be implied in those people to make them proficient? Like these movements are not good. They should make movement now this way so that they can reach to the same proficient level. Can you devise a model for further training to those people?
So actually that is why we really focus on error-based approach. So as we step away from these general metrics where we try to post a label based on general statistics, we really go for an error-based approach at Orsi Academy, where we look at the errors, focus on the errors, see if there's certain errors that are repeated by certain trainees, and then focus on the things that he or she is less good at based on the errors that he or she is making. So it's a bit of an advocacy to go to a more pragmatic approach based on errors than to go to statistics and general metrics as a whole.
I'm Dr. Shailendra Goyal from Noida. In this metrics, it is the instrument movement you are tracking, or it is the precision of surgery you are tracking? I could make out it is the movement. If the skewed movement, then you can pick up. But what about the precision? I think that is a different. You are tracking the metrics, whether the student or the trainee moves the instrument haywire or something. Or the precision you are also tracking.
It's mostly on the movement, as we have focused on these metrics because in a lot of work that does similar things, the metric called economy of motion is often used, which is as a widely used marker for trainer or a surgeon skill level on how efficient he or she moves the instruments. So as we wanted to benchmark our techniques to these widely used metrics, this is what we focused on for now. But of course, precision could be a future work where we can
precision
focus more.
Precision is a higher marker, but is the movement, of course, when the moves the instruments, that's also the part of the training.
Yes, so we have not done that yet, but it could be one of your future work.
I think the response to your question is no one has as yet figured out how to teach those expert movements to the next generation of surgeons. Not at least today, as in 2025. That is aspirational, but no one's figured it out yet. So, Doctor, please come and have a seat. Great talk. Dr. Ansari, I'll entertain the audience while your slides come up. So look, my name is Prokar Dasgupta. I was fortunate enough to have Raj Vattikuti inaugurate the Vattikuti Institute at King's in London in 2014, so thank you, Raj. And we have converted a part of our hospital into a virtual hospital. By that I mean at St. Thomas's, opposite the Houses of Parliament, you walk in, this is a real hospital, but there are no patients. Everything else is simulated. So it's called the Simulation and Interactive Learning Center, or SAIL Center, and after 23 years, this is the journey. So in 2002, we developed the world's first laparoscopic nephrectomy simulator, as you see here. The most difficult part of this simulation was building the fat around the kidney, and you can see this model, which took many years to build. With any simulator, you have one important word, and that is validation. Does it do what it says it does on the tin? And secondly, can it tell between an expert and a novice? So on these graphs, you see the novices in green and the experts in red. So the lower the value on the y-axis, the better is the performance. So this simulator was developed first by Tim Needus and then validated by a colleague over a 5-year period. So the problem with this is everything is in the lab. The one question this doesn't answer is, does it make a difference to patients? So the other part, which we have already been talking about, is the human factor side of it. About 20 years ago, Kamran Ahmed, now professor in Abu Dhabi, a brilliant young surgeon, at the time the only surgeon in the world with a PhD in surgical simulation, came to my lab. And his work was trying to develop those soft skills like leadership, like teamwork, which made as much of a difference as technical skills. Ahmed brought this from Roger Kneebone into our lab. And this is inspired by an igloo. Expect, it's a surgical igloo. So the story goes like this. An Eskimo learns how to build an igloo. So the child is taught how to build the igloo. And all parts of the igloo are built except one of the ice blocks is left alone. And that is the heaviest ice block. And the child has to learn how to lift that block into the right place. And he or she just can't do it without a team. So this is all about teamwork, and it is inspired by an igloo. So this is an igloo, and you see the surgeon with a HoloLens. This is a complete immersive simulation. The nurse is fake, but has a scenario. There is no patient. The surgeon is seeing everything in front of their eyes, just with a HoloLens. And it shows for the first time that if you immerse a surgeon into an igloo environment, you can improve not just their technical skills, but also their non-technical skills. Yesterday, we had a fantastic demonstration with the HoloLens. And again, it is kinder to the neck. Rather than moving your neck around, if you see everything in front, it improves your performance. Mahendra Bhandari yesterday said, is there any evidence that mindfulness can make a difference? This is Roger Federer. If you don't know who this is, then you need to get a life. But look at Roger's eyes. The eyes are on the ball. Something is happening inside his mind, which every sports person does. They are trying to fox the opponent, and it's not just the racket, it's also the mind. So this is the only randomized controlled trial from Nick Raison, who again was a Vattikuti scholar 10 years ago, where you are comparing mental imagery to see if you have better skills. So if you imagine a robotic procedure such as suturing and you go and perform it, you have better technical skills than if you do not. So this is what my trainees do routinely. When I presented this randomized trial for the first time to Andrew Hung and Indy Gill, I was their visiting professor, Gill came back to me afterwards and said, Prokar, this is all hokey pokey. ऐसा तो होता ही नहीं है. This is nonsense. You need to learn how to operate. This mind and all this is nonsense. So I went back to Raison. I said, look, one of the best surgeons in the world says this is all nonsense. So we decided that we had to have evidence. What did we do? We put our surgeons into a functional MRI scanner. And there is direct evidence that if you use mental training, you improve the connection between your prefrontal lobe and the frontal lobe. And that is how you improve performance. So on the right, you see that signaling here in the brain, and there's clear evidence that this is not hocus pocus. The final part of my talk is that we didn't want to leave this in a lab. At this point in time, about 10 years ago, there was no difference that expensive simulation made any difference to patient outcomes. This is called predictive validity, and we launched an international trial called Simulate, randomized to simulation versus no simulation in 15 centers in the world. So let me show you, this is 15 centers, and this is the trial design whereby eligible trainees either went into simulation or non-simulation arms, and they were randomized blindly into these two methods. And they were assessed by a score called OSATs. This is very rigid, and then the secondary outcomes were looking at how the patients did. A curriculum was developed around ureteroscopy because every urologist needs to learn how to do this. This was validated across 15 centers and also had a cadaveric lab. So this is a beautiful study. It took us 7 years to complete, and it became the PhD thesis of Abdul Latif Aydin, again a brilliant young surgeon. What I want you to take away from this slide is that over 1,000 patients across the world agreed to be randomized in this trial. I want you to look at the curve on the extreme right. In red, you have trainees who were on the simulation arm. In blue, those in the non-simulation arm. And this shows you that the more complex the procedure, the more proficient the simulation patients, the simulated arm becomes. This is a rat tail plot with gray being the simulation arm, blue being the non-simulation arm, and again showing that those who have simulation do better than those who do not. But this is the most telling slide from this paper. Above the x-axis are patients who were operated on by surgeons who had never undergone simulation, and below are those who were in the simulation arm. You notice here that the complications in those above the x-axis is far more than those below the y-axis. This is the first time in a randomized multi-center trial that this has been shown. And now simulation as a result of this trial is standard of care in the UK and is in every curriculum. It adds educational value. The higher the value above 4, the better it is. And these are the centers, including those in the United States, Canada, Europe, China, and Japan, which participated in this groundbreaking trial, which we published at the time in the most cited journal, surgical journal in the world. This led us to perform a multi-institution assessment of robotic surgery, the MASS project, in 5 European centers. And again, you will love this. We developed a benchmark. This was in the early days of proficiency-based performance, and we did not allow surgeons who did not get over that benchmark. So they had to keep performing the test repeatedly, whatever robotic platform they were using, before they were allowed to progress. Today, simulation is not just about moving pegs and learning how to suture. It is becoming more and more procedure specific. Where you go into a lab, you want to do a hysterectomy, you perform a hysterectomy rather than just move instruments around. So I think this is vital, and there are companies, including CMR, who are here, who are bringing in these VR headsets to try and do procedure-specific simulation. So where does this all fit in? First, you have e-learning, then you go into a lab, do dry lab, wet lab. If you have cadavers, then you can do those. And as Tony showed, you can use gel-based models, saving the money from cadaveric simulation. You need to do non-technical skills. This is for even the most experienced surgeons in this room. And then I would put to you that cognitive training, we have direct evidence that that can help. So my take-home messages are very simple. Simulation is now standard of care because it makes better surgeons. I have shown you that it reduces complications by 50% and major complications by 66%. This is absolutely now proven in a randomized trial. And therefore, I put to you that if it was your father or your mother, just so that you do not go and have a practice at them, so the next time you think about your patients, please go into a lab, practice the procedure, and then attack your patients. Thank you very much.
Probably if we make this one night before or one evening before, that training surgeon or somebody is discussed with the residents that you have to learn about it. These are the steps you have to simulate, and that's how you come out. Probably the training will become better, but this is not routinely done now, currently.
So let's see, I completely agree, but let's see, hands up, how many surgeons plan their procedures a day before or week before? So 70%, not bad. Yeah?
But not the routine one, the complicated one.
Plan everybody. Plan everyone. Why? I mean, tomorrow a hydrocele may not become routine if you have a catastrophic complication. But how many people think about their procedures on the morning of the operation? How many imagine the procedure? So this is 20%. So I think the skepticism among surgeons, Anand, is that we are all great people. We all really are strong men and ladies, and therefore we are infallible. So that's why no one thinks that you can train your mind to do better. If you see sports medicine, this is standard of care. The coach is telling you how to beat your opponent in the brain even before you walk out on court. And yet somehow we think as surgeons that we are so great we don't need to think about it. I mean, this will take years to change, but at least we now have a randomized trial showing that you can think and improve your performance. So I think this should become standard of care.
Want to add one more thing. I have been a part of a team of Dr. Anant Kumar and along with the Dr. Bhandari. As you have simulated the thing, it is a cricket team.
Yeah.
And the coach and the captain is sitting with the team to make a strategy. And I have learned with Dr. Anant Kumar, when we are taking any complicated case, we are discussing as a team member what is everybody's role, and we are at the same page what he is thinking. He will do first from this side, he will access the vein and all, what he will be doing, and we are on the same page. Then the results are better rather than he is only thinking and I am thinking else. So it is a teamwork. So every team member should be on the same page.
So this is agree. This is the cricket or the football huddle, where the entire team gets together, and those who are not part of the team really don't do well. So give you a classic example. I was just at a meeting of the football coaches, and these are Premier League football coaches. And there was an analysis of Harry Kane, at the time the England captain, missing this goal during the penalty which put England out. So Kane had hardly missed any penalties, and they were analyzing as to how, on that crucial penalty, he missed it. The difference was that there was no team huddle. So as soon as this stressful situation came, the team were standing somewhere else, and they left Kane as the captain to just stand there and hit the penalty. Huge mistake. If he had a team huddle with people saying, Kane, you're going to do this, you'd probably have put it in the back of the net. So exactly what you're describing. This happens in sports every day, and yet we do not accept this as surgery. The team is vital, the mental game is vital, and of course we have to learn to get better. Ralph Clayman has a question. I'm now trembling with fear because Ralph will ask me a difficult question. Please give a mic to Ralph Clayman.
Comment, Prokar. I agree with everything you've shown. I think it's very important. I had one question with regard to the value of a warm-up before you go into surgery.
Yes.
But the other thing is, we have all these sports analogies in urology, and yet we have no coaches after you leave the amateurs and go into the pros. Nobody goes into the OR, no attending, with a coach behind him or her. I think that is the major error. We squander these coaches, we retire them, we send them out to pasture because it's a rare surgeon that has a sufficiently humble ego to have somebody in their OR coaching them. This is a major mistake, in my estimation, in the realm of surgery. Just a thought for you.
You're absolutely right. So I now, I've used 4 machines in 20 years with the CMR and the Medtronic, and I'm not saying this because they're sponsors here, because they are newer machines. After 20 years of Da Vinci, I now practice, do the warm-up for half an hour before I operate on the patient. It's a backpack. I turn up early. I insist my team turns up early, and we do a warm-up. It helps. Secondly, when I wanted a coach and I went to my dean and I said, would you please coach me? He was about to retire. So I think the older generation do not necessarily make the best coaches. So I went to the professor of immunology, who is 6 years younger than I, published in Nature Immunology, and I said to her, Martha, I want you to turn up and coach me before an operation, particularly the difficult ones. She said, I don't know anything about surgery. I said, you know everything about decision making. Just want you to be there while I'm scrubbing and talk to me. And that has worked out. Sometimes having a younger coach and forgetting that you need someone older is a good thing, because the older generation are fading, but the younger are still there.
Good morning, everybody. And thank you very much, Vattikuti and Bandari sir, for giving me this opportunity. As we know that the computers and the AI are finding their newer and greater place in both medicine as well as surgery. So this is the computer-assisted surgery, which has many examples like robotic-assisted surgery, surgical navigation, and the image enhancement and the image fusion. And finally, the artificial intelligence and a combination of all. And the image fusion is basically defined when we have hundreds of images. You collect information out of that and create one principal or the mother image to get the best of the information. The basic idea of this image this fusion is to get the one principal image which has the best possible information, easy to interpret by surgeon as well as by the machine. It has a basic component in the form of registration and then acquisition and data interpretation. And we know that many examples of image infusion in clinical application, like non-invasive diagnosis of the posterior wall, one of the commonest cause of ESRD in the children, and finally the prostate cancer. We all know that. So the basic application of this is in the form of surgical navigation in studying or exploring the complex anatomy in multiple tumors, hilar tumors, as well as the complex vascular anatomy in cases of multiple vessels, as well as surgical navigation. So this is first one of the application of the case of this methodology in an 8-year-old boy. Who basically presented a tumor in the upper and the mid pole. This is the triple phase CT, which is showing 2 vessels, which is supplying to the area of the tumor. And you see the remaining parenchyma is supplied by the 3rd vessel. So how do we apply this image infusion finding? This is the DSA image of the same. this image interposition during the live surgery, you can help to find out and navigate the vessels. So we first attempted the upper vessel, which was going to the tumor. So this is guiding us how we find the upper vessel. So in real-time image interposition and exploration of these findings, when we have hundreds of images which have been analyzed by the computer during the clinical discussions. So we find the upper vessels, we dissect peripherally to around the vessel and put it on the ceiling. Then we target the lowermost vessel which is going to the remaining remnant of the parenchyma. So again, applying the enhanced imaging system that goes and that guides the system to target the lower vessels. So we find it, again clear it all around and put it again on another ceiling. So this is how this image enhancement, the image infusion that helps then for the surgical navigation. So we find two, upper and the lowermost, but the middle is still to be found. So how to find, these are the upper and the lower one. Two have been found with the same methodology. Now we go back to find, because we could not find any hint intraoperatively, we go back to the third. If you realize this, on this 3D model, we found that the third vessel is basically lying deeper as compared to the upper and the lowermost. Then we went back and analyzed and applied the same methodology, and we found that this is lying deeper as compared to the two previous vessels. You can appreciate in this, when we find this, there is a definitive difference in the level of the depth of the third vessel. You see here the depth difference between the two. The image infusion and the live application of the TEM during the surgery can guide you, help you, and avoid any inadvertent this injury to the vascular structure. So we cleared it around. Again, we put it in the third sling to proceed for the surgery further. So these are 1, 2, and 3 with the application of this image, this fusion technology for all the 3 vessels. So we went subsequently only for the selective clamping, because the third vessel has been only the vessels which are going to supply the tumor area only. We also applied the ICG just to mark to avoid the ischemia time, prolonging of the ischemic time also. Then with the cold shear, we excise the tumor out of the remaining parenchyma. And that was not very difficult once you have controlled the important vascular structures also. So this was the tumor which was taken out from the affected kidney. Yes. So to summarize, that the real-time image fusion technique allows surgeon to take advantage of the additional information to navigate safely and efficiently during robotic surgery, especially in the setting of complex surgical anatomy or multiple vessels. And with this, I thank you all.
Good morning. I'd like to thank the Vattikuti Foundation for the opportunity. I'm Dr. Thilak from Orthopaedics Department, Amrita Institute, Kochi. And I should say that I should thank the Striker and the Vattikuti for bringing the first robot to our hospital way back in 2017, I believe. So I think it was kind of a journey for us from there. Sorry. Okay, I would like to share a case, difficult case where we had to use this robot for joint replacement. I have nothing to disclose over here. So this patient came to us. She was a 35-year-old female who had bilateral knee pain. She was suffering from rheumatoid arthritis and was on disease-modifying drugs. And over the past couple of years, it's been terrible for her. And she came to us asking what more can be done to make her day-to-day activities better. On examination, she had a bad flexion deformity, fixed flexion deformity on the left side. The knee had kind of fused, and she had difficulty in walking. So this was how she looked like, and she had both the knees kind of fixed. And hope the video works. Yeah, okay. This was how she was kind of walking for her activities, and she was in a miserable situation. Okay, there were hardly any movements. The right side also had some movements, but very arthritic and painful. When we took an X-ray, we could see that on the left side, the knee had kind of fused. You can see the trabecula of the bone passing through and through. On the right side, she had almost a tricompartmental osteoarthritis. And she wanted to know what more can be done. And this was the time when we have a few experience with taking down these ankylosed or fused knees and doing a total knee replacement regularly. But this was the time when the technology was available to us, and then we discussed with the patient regarding the possibility of using a robot and trying to get her knee replaced. So she kind of agreed with that, and we went on planning. Our particular robot is a CT scan based system where we have to take the CT scan pre-operatively and then plan the case beforehand. And we have a macro product specialist who can come and help us with registering the bony anatomy. And once you register the bony anatomy, we feed it on back to the robot, and then we plan how appropriately we can put in an implant to get that joint working again. So intraoperatively and under anesthesia, you can see that she hardly had any movements, not much of instability at the knee as such, because it's a fused knee itself. And once we open the knee joint, we usually go by a medial standard parapatellar approach. We could see some of the joint lines, some of the areas of the bone which were not involved because of the fusion. Through that area, we could osteotomize freehand. And once we get the joint moving a little bit, we could see some of the areas of the bone were not involved or damaged too much. So those areas were taken and registered intraoperatively. So that was a tricky business, because you have to take the normal anatomy and give it back to the robot so that it understands what we are trying to do and give us a better feedback. So once we start registering and we got reasonable data, then we made sure that we got a reasonable anatomy, what we needed to register, and then we went ahead and started preparing the bone. The robotic arm comes and helps us preparing the distal femur and the proximal tibia in such a way that we take the bone which has to be removed appropriately, and an appropriate sized implant has to be put in. So once we got the trial implants, we could see that we had a reasonable range of motion in that fused knee, and the joints were relatively stable. We were worried about whether the collateral ligaments on either side will work or not, because the knee was fused for a few years. But luckily for her, the ligaments were relatively stable, even though we could see a little laxity on the lateral side. So we had kept as a backup a bit constrained, a semi-constrained implant, not the regular implants, in fact, if it was needed. And this is how the X-ray, post-operative X-ray looked like, with the implant in position and a reasonable stable knee. We did a simultaneous bilateral knee replacement because the other side was also painful, and she wanted to get going as fast as possible. And post-operatively, on the day one itself, we start the mobilization, because for so many years the knee has not been working. She had a tough time getting it going, but she was a nice patient and she was trying her level best to get the knee working. On the same day and the first day itself, we make them walk so that the joint starts working, and the muscles, ligaments, everything start working, and we can prevent deep vein thrombosis. So the first follow-up we usually get is at 6 weeks. She was happy that she had a lot of relief of pain, and she was religiously following the physiotherapy protocol, what we had explained to her. And this was the way she was walking when she came to us without support, and she was improving by every week. So at 1 year follow-up, she was pretty happy with her knee functions, and she was back to most of her day-to-day activities. And her range of movement had improved quite a bit, and the knee was quite stable, about 0 to 80 degrees we could get on the left side, and the right side was working as a regular knee joint replacements. So in conclusion, I'd like to say that to get a good functional outcome in these difficult cases, technology did help us to get that implant in good position and to get a good ligament balance. So that is where the robot comes in. Even though we have experience with the regular surgery, but the limb alignment in whatever philosophy, now the philosophy of limb alignment is going wild, and different philosophies are coming out for us orthopedic surgeons for joint replacement surgeries, and robot is playing a big way in helping those scenarios. I would like to share that we got this case published in the BMJ case report 1 month ago, and we are happy about it. Thank you very much for your listening.